This is PT Pro Talk, the podcast for physical therapists who want to improve their clinical skills and be more successful. I'm Mariana Parks, physical therapist and your host, and today I'm joined by Dr. Andrea Mosler for a conversation about groin pain in athletes. We discuss how groin pain is classified and how common it is among athletes, key causes of groin pain and how to assess them, and differential diagnosis, practical insights on imaging, evidence-based treatment, and rehab strategies for athletes, and more. Dr. Andrea Mosler is a specialist sports and exercise physiotherapist and senior research fellow at Trobe University. Her research focuses on hip and groin pain, injury prevention, and women in sport. She completed her PhD on groin pain in professional footballers while working at Aspetar in Qatar. Andrea previously spent 18 years as a clinician at the Australian Institute of Sport and was a team physiotherapist at the 2000, 2004, and 2008 Olympic Games. If you find our conversation informative, don't forget to subscribe, hit the notification bell for updates, give us a thumbs up, and share this episode with colleagues who could benefit from these insights. Thank you for tuning in, and now let's dive into the discussion. PT Pro Talk is only possible with the support of the forward-looking and innovative companies like Sarah Health. Remote therapeutic monitoring sounds great, but also difficult. Sarah Health makes RTM simple and easy for your patients and providers. Check out sarahealth.com/PTProTalk for a special offer. Neck Care.
Treating neck impairment? Get objective neck assessments with the Neck Care system. Learn more at neckcare.com.
Hi, Andrea. Welcome to PT Pro Talk. I'm excited to talk to you. So let's just get started talking a little bit about yourself and your background.
Yeah, thanks for having me on, Mariana. It's really a pleasure to talk about my favourite topic, which is hip and groin pain in athletes. And I started my career as a physiotherapist in Adelaide, where I grew up in South Australia, and did a postgraduate in sports there. And while I was doing my postgraduate is where I first became interested in groin pain. And I was treating a lot of Australian football players and having some difficulties in managing their groin pain. And then I moved over to the Institute of Sport in the mid-90s, and there I worked exclusively with elite athletes across various sports, but mostly water polo and gymnastics. And that sort of furthered my interest in groin pain in particular. And we were starting to see a lot of hip-related groin pain in our female athletes at the time, and that sort of developed my interest from a more academic perspective. And when I moved over to Qatar in 2013, that's when I started my PhD looking at the intrinsic and extrinsic risk factors for hip and groin pain in professional male football players. And once I came back to Australia and finished the PhD, I've been working at La Trobe University since then. And due to my long time travelling with female athletes with the National Women's Water Polo team, I've been moulding those two areas of interest and looking at hip and groin pain as well as the female athlete, and with a real focus on prevention. So that's
Very
me.
good. Long journey, lots of experience. That's awesome. Just a quick pause to share something exciting. I've been working behind the scenes on a tool to make prescribing home exercises easier and faster for PTs. It's built based on feedback from therapists who have told me they are tired of clunky search tools, limited customization, and complicated sharing. I will be sharing more soon, but if you're curious and want early updates, you can join the interest list using the link in the show notes. All right, let's get back to the conversation. So, how about we just start defining groin pain, hip pain, and their classifications?
Yeah, so this is something that really was a real area of controversy, I would say, through the 2000s, where we had a lot of geographical differences in how we defined groin pain and some of the terminology and taxonomy that was used for groin pain. And it was really necessary for us to come up with some sort of consistency in how we were defining the different categories of groin pain. And that's where the Doha Agreement in 2014 really has moved the field forward. So we've now been operating under that taxonomy for the last 10 years, and it's really improved our ability to synthesize the literature since then. And in the Doha Agreement, we had the 4 clinically defined entities of groin pain of inguinal-related, adductor-related, pubic-related, and iliopsoas-related groin pain, and then the 2 additional categories of hip-related groin pain and other, which is really the medical causes of groin pain. And since defining those categories and how we can use our clinical examination to categorise groin pain, it really has moved the field forward in terms of consistency in clinical research. So that's been of great benefit to the field. So for adductor-related groin pain, which is the most common entity seen particularly in male athletes, but also in female athletes, it seems, although it's quite difficult to do these large-scale prospective studies where we can look at the different incidence and prevalence of the different categories of groin pain. Hasn't been done that often, but what we do know is adductor-related groin pain is the most common entity in both males and females. And then it looks like iliopsoas-related groin pain is, or hip flexor-related groin pain is perhaps a little bit more common in women than it is in men. It is the next most prevalent category of groin pain. But inguinal-related groin pain is more common in men than it is in women, most likely due to the differing anatomy. And pubic-related groin pain is sort of fairly poorly understood. It was defined as a new category really in the Doha Agreement. And that's not as common. And hip-related groin pain is varying prevalence depending on the sport, but it does look like it's a little bit more common in female than male athletes. And then other really covers all those other medical causes of groin pain. So things like femoral neck stress fractures, testicular cancer, some of the gynecological causes of groin pain, nerve entrapment, such as ilioinguinal genitofemoral nerve entrapment. So some of those other causes of groin pain that are not clearly defined in the clinical entities I've just described.
Mm-hmm. Okay, no, that's a great overview. And talking about the athletic population, so what is the incidence and prevalence of groin pain?
Well, if we look at what we do know in male professional football players, we do see around 1 in 6 professional football players will experience groin pain. So it's 1 in 5. So the incidence is about it varies depending on the study, but it's around 1 per 1,000 hours. And it is the 3rd most common injury seen in professional male football players. The interesting thing is that it has one of the highest recurrence rates. So it is perhaps not quite as prevalent as something like hamstring injuries, but it's actually has a higher recurrence rate. Now, in women athletes, the incidence is a little bit lower. So we see around about double the incidence, double the prevalence in male athletes compared to female athletes when we're looking at time loss injuries. When we're looking at non-time loss injuries, it's perhaps a little bit less swayed towards males than females. So there might be a lot of grumbling groin pain that occurs in women that doesn't necessarily result in time loss. So sometimes it is just how we actually measure our burden of groin pain in order to give you precise sort of estimates. But in women, it's around about the fourth or fifth most common injury seen in professional women football players, and a little bit lower incidence, and around sort of 10% of women will experience groin pain each season, whereas 21% of men will experience groin pain each season in terms of time loss.
Oh, okay, great. And what are some key differential diagnoses for athletes presenting with hip and groin pain?
Yeah, that's a tricky one. So one of the big problems that we have with the hip is that we don't really have any tests that rule in hip in terms of our clinical examination. So often it's really our reports of area, depth of pain and aggravating activities that really can help us rule in hip. So one of the things I always look for is how they describe their pain. So someone with hip-related pain will often describe the C sign, where they grab the side of their hip and will put fingers in the front and fingers in the back. And that C sign, and describe it as a deep pain sort of between their fingers, will often alert me to hip pain, whereas with groin pain, they'll often really touch the structure much more superficially. So for inguinal related, it'll be very much around the inguinal canal and above into the abdominal region. For adductor related groin pain, they really very much go to the adductor tendon or adductor muscle belly onto the pubic symphysis. So it'll be much a clearer kind of area of pain with groin pain compared to hip. That's not the difficulty, is that you'll often see the other entities of groin pain together with hip related pain. So that then makes it quite difficult as to what to, do we focus more on the hip related pain, or do we focus more on the groin related pain? And we have really good evidence for management of our adductor related groin pain in particular. So sometimes I'll prefer to manage the adductor related groin pain and then see what we're left with. But yeah, it is a tricky one. So area, depth of pain. Pain with sitting is a classic. Pain with driving. So not when you're getting out of a car, because getting out of a car will be painful with both adductor related, pubic related, inguinal related and hip related groin pain. But when you just have that sort of deep aching with sustained sitting, that also alerts me to hip related pain, as opposed, especially if they're sitting in deep chairs or when driving, as opposed to some of the other categories of groin pain. In terms of our clinical examination, the problem we have with our special clinical tests such as FADA and FABER are that they are very sensitive tests, and we found in our professional male football players who were pain, completely asymptomatic, that around 6% will have pain with FADA. So even though they have no presence of pain at all. So it's a very sensitive test. It's very commonly positive with lots of different categories of groin pain, particularly with hip flexor related groin pain, where you're sort of squashing the tendon. And so it doesn't rule in hip at all. It's more that if those tests are negative, then we can, and the hip has normal range of motion, we can reasonably confidently rule out the hip.
Okay.
Yeah. So the differentiation of the different categories of groin pain is probably one of the areas that's most tricky, and I think has created this sort of clinical conundrum for a lot of people coming, new clinicians coming into this area. But the Doha Agreement really clearly sort of defines how to categorize the different areas of groin pain, and it's common to have multiple entities of groin pain, particularly long-standing groin pain. But basically, if you have pain on adductor resistance and tenderness over the adductor region, adductor tendon, enthesis muscle, you have adductor-related groin pain. So it's very clear and simple in how to define those different categories of groin pain, and it's really clearly outlined in the Doha Agreement.
Okay. So on these categories of groin pain, you separate them, you differentiate them pretty much by location, palpation. So it's very clear different areas are related to the groin pain, right?
Yeah. So resisted tests are part of the assessment for adductor-related groin pain and hip flexor-related groin pain. With inguinal-related groin pain, we also look at pain on Valsalva maneuver, but yeah, the palpation and area of tenderness is the key findings. Yeah.
Okay. And then when you go through the evaluation on the subjective, they're just telling you about the area. Is there anything that it's important to note on the subjective history that helps you mechanism of injury, or is just really the location or anything else that we have to pay attention to?
Yeah, look, I think there's a lot of in terms of the gradual onset of groin pain, that's really quite common that doesn't help you necessarily with the differentiation of the different entities. And they will often all have pain with running, often all have pain with kicking. So the behavior of the pain doesn't necessarily help you that much. Sometimes they will describe a sort of clicking and pain when rolling over in bed, and that's very much alerting more towards pubic-related groin pain. So the long-standing groin pain can sometimes be associated with pubic instability, and that kind of clicking or sharp pubic pain when rolling over in bed or when moving the leg out to the side, that can really alert you more towards the pubic-related groin pain. Pain with straining, pain with coughing, sneezing, very much alerts towards inguinal-related groin pain, but not exclusively. So sometimes you can have pain with coughing and sneezing. That's adductor-related groin pain as well. So yeah, it is a bit tricky in terms of the subjective examination, the area of pain and the aggravating activities and where they feel pain with those aggravating activities is probably the most important factor that we can gain from the subjective examination. As I mentioned about the hip-related groin pain, that is often a differentiating factor from some of those other clinical entities.
Okay. And then if you move on to the objective assessment, so you said resisted muscle tests, some special tests, right? Why do you think it's important to do on the objective to differentiate them?
Yeah, so I always think about the objective examination as divided into diagnosis or categorization of the groin pain. So certain tests that you want to do to sort of confirm your diagnosis that you're already thinking about from the subjective examination, and then the rest of the examination is looking at impairments. So your diagnosis is only a small portion of the of your objective examination. I think a lot of clinicians get caught in that trap of looking at things towards a diagnosis when, in fact, the thing that's going to really help you understand the whole problem in your clinical reasoning is really understanding the impairment. So thinking about what are all the things that have led to this body not being able to cope with the load that they've been able to cope with for other times of their career, or if it's a recurrent groin pain, what are some of the lingering things from their previous episode of groin pain that has meant that their body is vulnerable to another episode of groin pain. So in terms of the diagnosis, running through the Doha Agreement, our special tests, And then once we are comfortable that where our clinical reasoning is going, then we really want to find out, well, what's the impairments that are presenting. So then, we might look at some strength testing, and in athletes, I like to use eccentric break test for abduction and adduction inside lying. We have really good normative values. And with eccentric testing, we can often pick up deficits that are missed with isometric testing. So side lying, adduction, abduction is a really important component of the assessment, as long as their symptoms allow for that. Doing a squeeze test with a dynamometer to gain it's a pain provocation test, but to get a baseline score with that pain provocation test is a really important component of the assessment. Looking at core function, so looking at upper abdominals, lower abdominals, looking at some endurance tests such as plank to failure or Copenhagen adduction to failure, depending on their symptoms. Often that's too provocative a test to do on your first assessment. Looking at lumbar spine and quads function is another important thing. So sit to stand sort of test. Ankle dorsiflexion is another important impairment to look at. It's not uncommon to have history of ankle problems with limited dorsiflexion on the side that they then develop groin pain. So that's something else that's important to examine. So strength, endurance, range of motion, so hip joint range of motion may be an important component, but it's not clearly been identified in research for research purposes whether hip range of motion is important to measure or not. We couldn't agree on that in our Zurich consensus. So some clinicians and experts in the room and some evidence shows that it's really important, and others show it's not important at all. But muscle length tests are also considered to be part of the clinical assessment for the Doha Agreement. So particularly looking at a stretch of the adductors and stretch of the hip flexors can assist in your categorization of groin pain as well.
Okay, very good. And then in terms of imaging, is there any situation that you refer them to get an imaging to help on your diagnosis? Or for the most part, like your clinical tests are enough? Or when would you be prompt to refer them to get an image exam?
Yeah, that's a really tricky question. So we know that it's really common with hip and groin pain to have a lot of findings on imaging, whether they're symptomatic or not. So we see labral tears, we see chondral defects. CAM morphology is, up to 72% of players will have a CAM morphology in one or both hips for professional male football players. So it's more common to see a CAM morphology than not, and not necessarily related to symptoms at all. So it is sometimes a bit of a clinical conundrum when to send for imaging. We also see a lot of findings around the groin on MRI. So we see bone marrow edema up to a grade 3 in completely asymptomatic athletes. We also see a lot of reports of adductor tendinopathy and other extra-articular findings, which are not necessarily related to symptoms. And the prevalence of these findings are really very similar in those with and without groin pain. So there's certain imaging findings, such as the symphyseal cleft sign, which are more commonly associated with symptoms, but a lot of these findings are not associated with symptoms. So I think, so in terms of the clinical diagnosis, it doesn't necessarily help us with our diagnosis or our categorization. It's not needed for our categorization. So the time at which imaging may be important is for an acute injury. to look at the grade. For example, if they have a tear, it might be important to look for the grade of the tear, which can help potentially with the prognosis. But the other time in which imaging may be important, and I experienced this just recently, is when an athlete is not responding to management as we would expect. So I recently had a case of a young female gymnast who very clearly looked like hip flexor related groin pain. When we deloaded her and started on the early management, I would have expected a change of symptoms very quickly, like within 1 or 2 weeks. No change in symptoms, so we imaged, and she turned out to have a avascular necrosis of her femur, just the early stages.
Oh, wow.
So that's something to be alert of. If things are not progressing as we expect, then that's where imaging can be really helpful. And it's important, if there's any concerns about some sort of medical cause of groin pain, then imaging can be really important as well to rule those things out.
And talking about the medical causes, what are some known non-musculoskeletal causes of hip and groin pain that we should be aware and consider?
Yeah, well, I mentioned one, avascular necrosis of the femur, femoral neck stress fractures. Prostatitis is a well-documented cause of groin pain that's medical and requires medical management. Testicular cancer is definitely something we need to be aware of when we're dealing with young male athletes. Some of the gynecological causes of groin pain, so endometriosis, ovarian cysts can often mimic musculoskeletal causes of groin pain. Perthes disease, some of our stress fractures around the pelvis are always need to be on alert for in terms of our differentiation of groin pain. So we can have sacral stress fractures that can mimic groin pain, pubic stress fractures as well. But femoral neck is probably the one that we need to be on alert for, particularly in female athletes.
Okay. And now just moving on to rehab. So what are some strategies that we can use, progressions, to treat these athletes?
Yeah, so I always have a sort of divide the rehab into kind of an early, middle and late stage aspects of rehab, and with progression based on our pain provocation tests and some of our normative data. So the early stages, and really very much based on the impairments that we found during our assessment. So the early stages of management of groin pain, it's really important to settle the tissues down. So using things like isometrics and deloading are really our main strategies for reducing pain. But even using things like taping can be effective for reducing adductor-related groin pain, compression shorts. These are all soft tissue work. These are all modalities that have been shown to be effective at neuromodulation for groin pain. So use those, all of those sort of techniques that are needed to settle the symptoms down in the first place. And then it's really a matter of using exercise to gradually reload the tissue, but also using exercise to address the impairments. So all of my hip and groin pain patients will work on trunk and core strength and stability, and looking at pelvic position and trying to ensure they have a strong, stable base in which to move the legs on the trunk. So I will start, as long as it's not pain producing, I will start with core strength really early in the rehabilitation. And then in terms of, say, for an adductor-related groin pain, we might just start initially with isometrics, such as squeezing the ball between the knees until they're ready to start sort of single leg resisted adduction exercises. And you might start them in side lying initially, but very quickly get them up into standing and doing adduction strength with a band or with a cable, and then gradually increase the load, increase the speed, and increase the sort of plyometric action by including things like, maybe slide board or lateral hopping, lateral stepping, etc., to change in direction type activities. And then really your late stage is more looking at on-pitch type activities and just gradually increasing the tolerance to that sort of load. And really the principles of rehabilitation are very similar for all entities of groin pain. So if it's a hip flexor related groin pain, I will go through those very similar principles, but focusing much more on sagittal plane activities to address the hip flexor related tissue. But at the same time, a lot of the impairments will be more in that coronal plane. So we might need to, in terms of our impairments, address in our rehabilitation a lot of that lateral stability, because what we'll often find is that our hip flexors will be overloaded because the athlete doesn't have very good coronal plane stabilization. So they might be overusing their hip flexors because they might not have good action of, say, glute med and adductors in terms of stabilizing that in that single leg stance position. So it depends on the impairments that you find, but often in terms of addressing or preventing recurrence of injury, we need to look at what's dysfunctional about the movement and the capacity of that limb to tolerate the load that's continually aggravating the tissue that is presenting with pain.
Okay. So you mentioned the adductor, then the hip flexor. So it would go through like a similar progression, trying to start with isometrics, reduce the pain, and then slowly load the tissue, right?
Exactly.
And then with abdominal related groin pain, would you do the same thing, trying to just work the abdominal muscles?
Yeah, so with inguinal-related groin pain, we have a couple of papers that have been published now, showing efficacy of conservative management of inguinal-related groin pain. It's the one clinical entity where we have really good results from surgical management. So it's very common for inguinal-related groin pain to move quite quickly to surgery when we're looking at professional athletes. But there's some reasonably growing evidence of efficacy of clinical of non-surgical management for inguinal-related groin pain. And it does, the problem with non-surgical management is we do need time. So often for particularly long-standing groin pain, we do need around about 6 to 12 weeks of rehabilitation time. So for inguinal-related groin pain, often a professional football player doesn't want to spend 3 months rehabilitating when they know they can have surgery and be back in less than that. So, but for a lot of other reasons, we may not choose to proceed to surgery. Maybe they've had a failed surgery on the other side, or it doesn't fit with their timing. So there's a lot of reasons to attempt non-surgical management of inguinal-related groin pain prior to deciding whether surgery is the the preferred management. And so I do a lot of work on transversus abdominis, understanding and trying to improve the sort of stiffness through the pelvis. So often there's a disconnect between lower abdominal stabilizing the pelvis and movement of the limbs. So do a lot of work on sort of movement quality with inguinal related groin pain, but also strengthening in terms of the abdominals and that real differentiation between pelvic position and stabilizing the pelvis and loading the limbs so that they're able to better create that sort of closure around the inguinal superficial inguinal ring.
Okay, and then if they go through surgery, what are they doing on surgery in that specific case?
Yeah, it's a modified Bassini repair. So now they basically just do a fairly it does depend on the surgeon to a certain extent, but the most common operation is really not terribly invasive, where they just kind of do some stitching just to increase the tension through the area, and it's really small scars now. It used to be quite a big operation, but now they really try to do a minimally invasive modified Bassini repair. Some surgeons will also do an adductor tenotomy at the same time if there's chronic adductor-related groin pain at the same time. But we found in our research that those that had adductor tenotomy in conjunction with the inguinal repair will have about 30% loss of adduction strength, even 10 years after their surgery. So they never really regain their full adduction strength. So it's just something to be aware of, that the adductor tenotomy can be beneficial in terms of reducing pain, but we may render the area with that 30% sort of impairment of adduction strength, so that could lead to other problems. So I think when we're looking at deciding on surgery, that's an important conversation that we need to have with the surgeons.
Yeah. Okay. And how about the pubic related groin pain? How do you manage that?
Yeah, so pubic related groin pain can be the most difficult. So one of the things that we have become a lot more aware of in recent years is pubic apophysitis, which is really a growth-related injury and appears to be more common in males than females. And we know that the growth plate in the pubis does not fully develop or mature until up to 24, 25 years of age in some males, where it is the last growth plate to fully mature in the body. So our awareness of pubic apophysitis has become much greater in recent years, and there's a lot of work being done in Norway looking at greater understanding of the prevalence, and particularly looking at the prevalence in female athletes, because it's something we don't know anything about. So pubic-related groin pain, the first thing we need to be aware of is not missing a pubic apophysitis. And if we have a young athlete with a very sort of sudden and quite severe presentation of pubic-related groin pain, that should be something that's always on our radar. And the reason why it's important is because we manage them very differently. So pubic apophysitis, just like a lot of our other growth plate-related injuries around the body, really needs rest. And we have to be very careful in terms of loading. And they will often respond really quickly to deloading. but we have to be really careful not to accept pain during rehabilitation for these athletes. We really want to start our rehabilitation in a pain-free state and continue our rehab in a pain-free state. Whereas with more long-standing related groin pain, it's okay to accept low levels of pain with rehabilitation, like 2 to 3 out of 10 is actually fine to accept for like most of our tendinopathy kind of rehabilitation. It's okay to have a little bit of pain. But with our pubic related groin pain due to pubic apophysitis, it really rehab needs to be conducted in a pain-free state. So that's one diagnosis for pubic related groin pain. Another diagnosis for pubic related groin pain could be with pubic instability. And this is not uncommon, particularly in women postpartum. And that can be really tricky. Like, it can take a really long time for the muscles to kind of make up for the loss of structural stability across the pubic symphysis. But if you very slowly progress and very careful with reloading, particularly single leg type reloading, they can do quite well. But I would suggest with if there's pubic instability present, then you're looking more like a 3 to 6 month rehabilitation rather than under 3 months. Yeah.
Okay, that's a longer time. And how about the hip-related groin pain? Any tips on the management?
Yeah, so with hip-related groin pain, one of the most provocative activities is deep flexion. So very commonly, they will have pain with bilateral squat, and as we know with athletes, that's one of the mainstays of our strength and conditioning management. So often, if we can just prevent athletes from doing deep squats under load, that can make a really big difference for hip-related problems. So I will always modify their squat. They can do heavy squats, but just modify the range. So just keep it within a pain-free range. So that's probably one of the biggest tips I can give anyone working with athletes with hip-related groin pain is keep them out of the deep flexion loading in the gym. And same with deadlifts. So deadlifts are a really excellent exercise, and single leg deadlifts in particular are really excellent for hip-related groin pain, but we just don't want to load in that deep flexion. So keep your flexion less than sort of 100 degrees, 90 degrees of hip flexion, and you'll see some benefits with that.
Okay, great. And do you think it's common to see someone have more than one category of related groin pain, like from different muscles, like have the hip flexor and then the adductor, or is usually like one thing?
No, it's actually really common to have multiple entities of groin pain, and you can, we particularly with long-standing groin pain, around 40% will have more than one clinical entity. And the more clinical entities you have, the longer it takes to rehabilitate. So often it's a poorer prognosis if they have more than one clinical entity. So if someone presents with 3 clinical entities, then we really need to be looking at least 3 months of rehabilitation, probably looking more 3 to 6 months of rehabilitation to be able to manage that all of the different impairments and tissues that are involved in terms of the source of groin pain. So yeah, that's something to be aware of, that it's not necessarily the case that it'll take longer, but just to be alert that it's likely to take a little bit longer than a single entity of groin pain, which is it's a more defined kind of overload that we can manage in our rehabilitation.
And then you usually manage one at a time, or you start slower with a little bit of each?
Yeah, I will manage all at the same time. I think that's really important. And I often get the question of, well, do you label which is the most important? And I think in our clinical reasoning, it is helpful to try to define or understand or appreciate which of the clinical entities is providing the greatest contribution to their presentation of groin pain. But often it's really the impairments that are the things we're targeting with our rehabilitation. So the impairments may be the same regardless of which is the final tissue that becomes overloaded and produces pain. So it won't necessarily change the impairments, but it certainly will change that early stage. We're trying to think about what type of neuromodulation I will include in the rehabilitation. So what type of soft tissue work or dry needling, or do I use compression shorts or not, or do I use taping or not? Do I give them some form of gentle mobilization if it's a hip-related groin pain, whereas with adductor-related groin pain, we know that stretching makes them worse. So those kind of things will maybe change depending on the entity. But no, I tend to want to address all sources of pain in that early stage. So I will treat all at the same time.
Okay. And then as you were talking, is it usually the time frame to treat those conditions, if it was just one, usually under 3 months or about 3 months? And then if it's more complex, 3 to 6 months, would that be like a reasonable time frame?
Yeah, definitely. And, really I'm referring here to long-standing groin pain, which is what most of us will be presented with. But acute injuries will be much quicker. And obviously that will depend on the grade. But just to be aware that it's a really common scenario for, a relatively simple acute adductor muscle strain to later develop into long-standing adductor-related groin pain. So even though it might be sort of relatively quick to get a player back to return to play following an acute adductor-related strain, it's really important to address some of those impairments and to ensure that they have full restoration of outer range strength as well as eccentric strength and function before allowing them to return to play, because that risk of recurrence is a very real one.
Mm-hmm. And just quickly, I wanted to ask about the causes of all these like related groin pain. Is it like muscle weakness, is imbalance, is overload? What do you think is the most common causes?
Yeah, I think it's different for different athletes. It's very common. Overload is very common because it's a gradual onset injury, and it's often develops insidiously. It's often associated with increase in load. That even though we haven't been able to establish that with research, clinical expertise will say that it's often associated with overload. What we don't know is what type of overload. Is it specific overload within particular movement patterns, or is it just a general training overload that is related to development of groin pain? But yes, we don't know what type of overload, but it does appear there is some form of overload that is related. Very commonly, it's that capacity to stabilise in single leg stance, which is related. We don't see a particular. There's it looks like there is slightly more seen in the dominant leg, but it's not really obviously found in kicking legs. So it does seem like it's much more about change in direction than kicking. So it seems to be that capacity to stabilise on a single leg, particularly outside our base of support. So that's that kind of whether it's an imbalance or a loss of stability or an overload of those movement patterns, that seems to be the key mechanism.
Okay. And any tips to prevent them?
Yeah, we do have pretty good evidence for prevention using the Copenhagen adduction exercise in pre-season and during the season. We know that we can certainly reduce non-time loss groin pain up to 40%, but perhaps not quite as clear with women. So we do see some reduction in the prevalence of groin pain using more of a multimodal neuromuscular program in women. But this is not necessarily less effective than the Copenhagen adduction strengthening that seems to be more effective in men. And that might be because of the slightly different patterns that we see in women compared to men, where we do see a higher percentage of hip flexor related groin pain, which the Copenhagen adduction doesn't really address. So this is something that we're looking at in the Norwegian female football players to see if there's a different strategy in terms of prevention that for groin pain in female football players. But certainly, yeah, if I was working with a football team or any other, basketball team where we do see a high prevalence of groin pain, I would be including the Copenhagen adduction in warm-up, particularly pre-season.
Awesome. And I know you have a lot of small videos that I found online that show you the exercises with like some patient performing. So that was really cool. If people want to go check that out, that was very helpful. I know we are out of time. So Andrea, if people want to learn more about this topic, any resources? Is there like protocols that people can look? What do you recommend?
Yeah, there is a lot of publicly available articles and videos on YouTube that people can look for. Andreas Cerner and I have a video that we conducted in Aspetar where we look at some of the assessment of impairments in groin pain, and that's publicly available. The Barcelona Muscle Guide is a really nice and the Barcelona Tender Guide are really great clinical guides for clinicians working with football players in particular on management of groin pain. And there's also other podcasts and I know Physio Network. There's lots of online education tools that clinicians can go to if they want to learn more about all aspects of groin pain, whether it's the causes, the assessment, the management, prevention. They're all included in a lot of the education products that are available.
You also have a course on the Learn Physio, right?
Correct. Yeah.
Yeah. Awesome. Anything else that we forgot before we wrap up? Any considerations? Anything that you want to mention?
Yeah, look, I think Mariana, groin pain is one of those areas like the shoulder where a lot of clinicians are quite fearful and feel like it's too complex to be able to manage it. And I think that's the advantages of the Doha Agreement, that really it's about making the complex simple and looking at those, the different categories of groin pain, and then looking at the impairments and managing the pain as at the same time as managing the impairments, and then just gradual progression and just being really sensitive to the pain that's being produced in those pain provocation tests. So using those pain provocation tests to really determine when you progress your load. So for me, don't be fearful of hip and groin pain. That would be my biggest tip. Just be methodical and systematic, and your patients will be happier.
Awesome. And if people want to find you, where they can look for information about you or your papers?
Yeah, look, it's always a good source of looking just at Google Scholar, and that has a list of my publications. And through the Trobe University website, they can also learn a little bit more about my background and also some of the conference presentations, which is more recent. More recent studies that are perhaps the articles are in preparation. But as you mentioned, I have a course on Learn Physio, also on Physio Network, and there's other publicly available webinars that they can search for.
Awesome. Thank you so much for your time. It was a great conversation, learned a lot, and I'm sure everybody else also learned a lot. So thank you so much, Andrea.
My pleasure. It's lovely to meet you, and good luck in managing hip and groin pain, everyone.
That's all for today's episode of PT Pro Talk. We hope you enjoyed this discussion. Be sure to follow us wherever you listen to podcasts so you'll be notified when we release future episodes. You can also join our email list at ptprotalk.com to receive updates and access new episodes. If you have ever gotten value from the show, please take a moment to leave us a 5-star review. It always makes my day and it really helps us out. If you have any guests or topics you'd like to see on the show, let us know by answering a quick survey. You can find the link in the show notes along with more information about our guests, resources, website, and social media. Thanks again for listening, and until next time.